Hello, friends. I'm back again. Yesterday, we were discussing what are the indications for fertility preservation, what are the options that we have in fertility preservation, how the counseling should be done, etc. Today, let us look at the actual options and what are the things we do in detail as far as fertility preservation is concerned. So, what are the types of fertility preservation? Of course, the first one is the male fertility preservation, which we, again, as an infertility specialist, undertake. Maybe we will keep their semen cryopreserved, or we will retrieve their sperms if they have already undergone some treatment through the testicle from the testes and things like that. But the main aspect of our fertility preservation revolves around female fertility preservation. And in the affluent countries nowadays, even transgenders ask for these fertility preservation, especially if they have to undergo some gonadectomy in the teenage. Before I go, actually, whom should we offer? What do we offer? How do we offer? We should be very clear who should not be offered the fertility preservation. If there is established premature ovarian insufficiency, whether it is due to cancer or cancer therapy, or even otherwise, like day before yesterday, I gave a talk on premature ovarian insufficiency. So if you have established that, there is no point in offering fertility preservation for them. The best option for them is egg donation only. So this has to be very clear. Otherwise, we are simply duping the patient by giving the drugs unnecessarily. We should never, ever, ever try to exploit the patient's problems. This is one of the very, very important aspects younger generation should know about it. Other day, I was reading one article that some doctor, I don't want to name or tell the country name also, that he was giving unnecessarily cancer treatment for the patients who are not having cancer. So that is totally unethical. We should never come under any pressure with regards to the treatment of the patient. Ethical compromise should never, ever be done. This is very important. So if the AMH is less than 0.5 or antral follicular count is less than 5, or if the age is more than 36, these are the patients also better not to go for fertility preservation. They are better tackled again with home donation, like premature ovarian insufficiency. They do not have premature ovarian insufficiency, but they have very, very poor reserve in the ovaries. Then there's another category where we offer with caution. Number one is those who are in the palliative stages of cancer. Again, it is unfair to offer them because they would have already had suffered with the fertility loss. A big damage would have occurred because they are in the palliative stage. And sometimes patients, hope against hope, but it is we doctors who have to give them the correct perspective. Of course, the final decision is with the patient, but we help them take that decision jointly. Posthumous retrievals. This is another very, controversial area where after the death of a person, we try to remove the sperms from the testes. So that again should be offered with caution. It may be possible or not possible. They are good or bad or whatever. If welfare of a child is a concern, like both partners in palliative stages, and they want to have a child, but both of them may die after some time, and what happens to the child? So these are the concerns. Of course, it's a social concern, social issue, but we doctors definitely have a role in helping the couple to take a right decision. So these are some of the cautions which I want to tell before I get on to the actual treatment. So ovarian reserve in women with BRCA mutations experience menopause 3 to 4 years earlier than healthy controls. So this is very important to understand and know so that we offer fertility preservation well in time. Without even any treatment that we offer for BRCA mutation patients or before taking the ovaries out, they would have a menopausal sort of situation early. BRCA1 have low AMH, so obviously after the previous slide, I'm sure all of us would do an AMH and a follicular count minimum before we offer the fertility preservation. No significant association between BRCA2 mutation status and AMH levels. However, it's only with BRCA1. Possible that these women are more prone to chemotherapy-induced loss of ovarian reserve and ovarian insufficiency. Ovarian stimulation in women with the breast cancer by using aromatase inhibitors, that is letrozole, for fertility preservation can have its own problems because that itself may sometimes promote the cancer progression. Significantly lower ovarian response rates in BRCA mutation carriers, particularly among those with BRCA1 mutations. So, what are the options that we have? I've already spoken in a short way yesterday, but today I'm going to deal it in a very elaborate way. For male or trans women, sperm cryopreservation, obviously. Next is embryo cryopreservation with the partner. I have told you yesterday also, today also I'll repeat, embryo cryopreservation is the best. Next best is sperm cryopreservation. Why I put it as number 2 then? I put it as number 2, then maybe they would not have been married because trans women, especially, they undergo gonadectomy in the younger age group. So sperm preservation basically. But if they are married, of course, then embryo cryopreservation should be given the priority. Surgical sperm retrieval, this could be done anytime later, even after the death of a person, as posthumous sperm retrieval is sometimes done. Testicular tissue cryopreservation is another option, like we do ovarian tissue cryopreservation. As far as female or trans men is concerned, oocyte cryopreservation, though the number 3 compared to the embryo and sperm, but it is an option. And embryo cryopreservation with the partner S, again, I put it as number 2 here also, but it would be number 1 in a married couple. Ovarian tissue cryopreservation, if not oocytes, as I said, if you don't want to waste time, if you want to start chemotherapy immediately, then ovarian tissue cryopreservation is the better option than oocyte cryopreservation, because oocyte cryopreservation requires ovarian hyperstimulation that will take time and it will delay the chemotherapy. Ovarian transposition, if pelvic radiotherapy is given, this is easier said than done. As I said in another talk, that there will be some amount of scattering of the radiotherapy, even if you transpose the ovaries. GnRH agonist protection in females with cancer. So this I'm going to talk a little later in the end, in detail. This is something like photo protective type of a therapy. As I said, we have to have certain cautions. We have to be careful before offering the fertility. So investigations play a major role in our decision making and counseling. AMH, number 1, A for AMH. This is in all my infertility talks or fertility talks, or whatever I say, ovarian reserve or poor response, wherever I say A for AMH, A for AFC. It's not A for apple. So A for AMH. In fact, now I want to order them. A for AFC, because AMH gives you a general idea about ovarian reserve, but AFC gives you the idea about what are the available follicles in a given cycle. So because you can only harvest those follicles which are already there in that, recruited in that particular cycle, you cannot create new eggs. That's a basic thing, right? So obviously the next one is antral follicular count, and check ovarian axis for transvaginal oocyte retrieval, because sometimes if the ovaries are enlarged due to endometriosis or due to the cancer, you should know whether I'll be able to tackle or I'll be able to approach these follicles for the retrieval. So this is assessed together when you do transvaginal sonography. Estrogen receptor status assessment in breast cancer, especially because if unknown, treat as ER positive. So when you give the drugs, fertility enhancing drugs, that itself may promote the cancer. So estrogen receptor status has to be estimated. The other things are routine, like HIV, HBsAg for B, hepatitis B, hepatitis C, VDRL. These are needed to be as a prerequisite to store these gametes or embryo. So now I have come to the actual treatment, which I'm going to elaborate. Number one is oocyte and embryo vitrification. This is a gold standard of fertility preservation in female cancer patients. So number one is again embryo vitrification. Number two is oocyte vitrification. I've told this many, many times so that it is very clearly imprinted in your minds that embryo vitrification is always better. Number two is sperm, and number three is oocyte. So oocyte and embryo vitrification, you can do initially controlled ovarian stimulation protocols of oocyte retrieval in 2 weeks. This is same as any IVF protocol. High estradiol levels during stimulation hormone in sensitive breast cancer is modulated by administration of aromatase inhibitors, letrozole, or selective estrogen receptor modulators like tamoxifen. Vitrification clinical outcomes in cancer patients are comparable with those of fresh oocyte. So there is no issue about that. The stimulation protocols can be anything. There are several protocols that are there. That's why I'm not going step by step. I'm showing all the things at a time in the slide. It can be short protocol, random start protocol. If urgent, random start is the best. Start with the antagonist along with the stimulation because you don't have to wait for the either the withdrawal bleeding or you don't have to wait for the natural menstruation. So today the diagnosis was done. From tomorrow, you just give an antagonist and then start off. Double stimulation is another option, which I'm going to talk in detail later. Long protocol, if she's not urgent situation, then you can start with the previous cycles luteal phase. You can start GnRH agonist, not antagonist. Concomitant anti-estrogen letrozole in ER positive cancer and transmit. So these are some of the stimulation protocols. What are the challenges for fertility preservation in onco-fertility? If the background or poor reserve, time constraint, minimum 2 weeks are needed for stimulation. Use random start protocol in such situations. Tackling high estrogen, again, I've mentioned this, start with letrozole or tamoxifen. There's always a risk of OHSS. Monitor closely and avoid HCG trigger. Poor response to ovarian stimulation, then you can use dual stimulation. So these are some of the protocols, which is a conventional start where you wait for the withdrawal bleeding. If the diagnosis to withdrawal bleeding or to the normal menstruation is not very far away, and then suppose the patient says, I'm expecting my periods in another 3 days, then there's no need to do anything. Go for a conventional start. So once there is a menstruation, or you can start with a one short course of progesterone and withdrawal bleeding. Within a week, it happens. So you can start off with the initial aromatase inhibitors plus minus along with the gonadotropins. Aromatase inhibitors are used in cases of BRCA positives or breast cancers. And then, of course, you use the usual GnRH antagonist after the protocol, whatever the protocol is in your center. Then go for HCG or GnRH agonist trigger, then oocyte retrieval. This is normal. So I don't have to explain this any further. Whereas you can do what is called luteal halt. Suppose there's still a lot of days for the next menstrual cycle. Then what you can do is you can give a GnRH antagonist. Then you will have a withdrawal bleeding. And then you go for the same protocol as in the other side, that is number A. So one more way is luteal phase start. Suppose you feel that there is a lot of time, then you can go for GnRH agonist, a long protocol, what we used to do in the past. I don't think anybody uses that nowadays, so I don't want to elaborate that any further. And finally, you can go with another protocol, which is the initial visit happens after the spontaneous LH surge, meaning she's in the luteal phase. But you can straight away start with GnRH antagonist here, something what I explained in a earlier slide, and then go for the usual stimulation. Basically, what I want to tell you is that because of the urgency to start the chemotherapy or radiotherapy or whatever, or surgery, whatever it is, you don't have to wait for the usual traditional way of waiting for a withdrawal bleeding or a natural menstruation. You can straight away start with the GnRH antagonist and quick withdrawal, and then you can go for usual stimulation. There is a dual stimulation protocol, which is a talk by itself. But to tell you in short, it's a relatively higher dose of gonadotropins that are used compared to that used in infertility patients undergoing routine IVF. Dual stimulation itself shows that double time. We are doing it continuously or successively 2 times. We are not waiting for the lady to menstruate. Once we retrieve the eggs, immediately we start with another stimulation cycle. That's as simple as that. It commences with a random start antagonist stimulation protocol. As I said, whenever you want to start, you can start by just giving one antagonist. There will be withdrawal bleeding, and then you can start off. Women with an estrogen receptor positive breast cancer, this I've told many, many times, you can add aromatase inhibitors along with that. So this is how dual stimulation protocol looks like. So day 2, you can start off with the FSH plus antagonist as usual, trigger, and then OM pickup. Now look here. Soon after the OM pickup, you don't wait, right, for the withdrawal bleeding. And you are not even actually transferring the embryos because the embryos are being frozen. You immediately start with another stimulation with FSH antagonist, and throughout you are giving letrozole to cut down the excess estrogens, and then you retrieve again. So this is how a double stimulation protocol will work, and so that you can collect as many eggs as possible. And if she's married, you can fertilize all of them, and you can preserve the embryos rather than preserving the eggs. So this is all like a fast track. It's like a fast track. So dual stimulation protocol, the points to ponder are oocytes are exposed to high progesterone, that we should know. Effects not sure, but no difference in the quality of oocyte as such. The time frame to be discussed with the oncologist whenever you give these double protocols. 2 egg collections, of course, doubles the risk of infection and thrombosis. See, too much is too bad. This all of us know. In a span of maybe 1 month, you are trying to do 2 oocyte pickups, and each time there is a chance of infection, chance of thrombosis, hyperstimulation. All these risks are there. It's a basically very tightrope walk. It's a very well considered decision. It's a decision taken in the interest of the patient. So that doesn't mean that we can be rash, we can be ruthless. We have to be very careful, right? So the next one is high estrogen levels for hormone-sensitive tumors. It has to be always kept in mind. Evidence not clear whether there will be proliferation, dissemination because of the estrogen. So whenever we stimulate, we all know that there will be high estrogen. Per follicle, it will be almost 200, right? So there will be high level of estrogen when we stimulate. That itself might sometimes harm or the progress the cancer very fast. Number of oocyte receptors may be increased with double stimulation. We know that. Oocyte quality, there's no change with random or dual stimulation protocols, so you can go for that. Oocyte cryopreservation, of course, 7 to 8 or per 10 per 10 will survive. We know that. That's why we would like to have as many eggs as possible. 20 oocytes at least we should have. It's a good number. Vitrification technique, of course, it depends upon the center, and the embryologists are the best persons to decide on that. Attrition at every stage should be kept in mind. Not all survive, not all will fertilize when we thaw them. ICSI is required for fertilization, no doubt in that. Benefit, reproductive autonomy when there is no partner. So this is the advantage of oocyte cryopreservation. They don't know whether they have a partner, they are going to marry or not marry. I mean, things are very undecided at this stage. Whether she will survive in the first place from the cancer that she has got. And then comes the issue of her getting married or having a partner who is compassionate, who is understanding, and who would give his sperms. So these are all certain issues. So in those undecided or dilemmatous situation, oocyte preservation is the best. The next best, when there is no time to spare for ovarian stimulation, best is ovarian tissue cryopreservation, what is called OTC. Is an alternative option in FP. for female cancer patients again. So here also, where oocyte cryopreservation is not feasible because of the time constraint or not opted by the lady, or if it's a girl, young girl of post-pubertal girl, where stimulating her itself is not a good idea. In fact, in many countries, including India, we cannot do ovarian hyperstimulation in a teenage girl less than 18. So that is why it's sometimes better to go for ovarian tissue cryopreservation. If already received low toxic treatments, then there's no point in going for the oocyte retrieval. Better to take a healthy ovarian tissue, though it may be contaminated with the cancer cells already or cytotoxic agents. Slow freezing is recommended and not vitrification. It is not definitely advised in trans men. Decision for OTC, of course, the age should be less than 38. That itself is high. I would prefer less than 35. Ovarian cortex to remove, it estimated risk of ovarian failure related to planned treatment and existing ovarian volume. Pelvic irradiation, TBI, and high dose of alkylating agents, endoferectomy. These are some of the issues that we must keep in mind before we do this ovarian tissue for vitrification or collection. Oophorectomy in young girls owing to small size of the ovaries. This also may be a issue there. So we have to keep all those things in mind. Ovarian tissue cryopreservation, it is still considered experimental because whether this tissue will survive, will not survive outside the body. Eggs, we are very sure. Sperms, we are sure. Embryos, we are sure. But the tissue as such, whether when you transplant back, whether it will start growing back, is still not very, very clear. OTC and retransplantation is only performed in a few centers worldwide. So that's why I said it is experimental. Ovarian tissue can be retrieved either by ovarian biopsy or oophorectomy, which the ovarian medulla, after which the ovarian medulla is removed and the cortex containing the primordial follicles is cryopreserved. So medulla is just, we know, connective tissue and other things, but cortex is the one which has got all the follicles. Ovarian tissue cryopreservation, since ovarian cortex is grafted as a avascular transplant, follicle depletion occurs during the first days after grafting due to ischemic damage. So this has to be kept in mind. Leukemic cells can cause recurrence of the disease when reintroduced into severe combined immunodeficient mice. This is an experiment. OTC is restricted to malignancies that do not affect the ovary directly. It may be other cancers. Histological analysis may be helpful, but not enough to rule out the possibility of contamination of malignant cells within the tissue. Some of the techniques, as you can see, 1 to 1.5 millimeter thick biopsy of the ovarian cortex is taken. Primordial follicles can be found at the distance of 0.8 millimeter from the mesothelium. Transport time be reduced as much as possible. So this is a laparoscopic retrieval of the ovarian cortex. Reimplantation of ovarian tissue, it could be orthotopic in the pelvic cavity on the remaining ovary or close to it, or heterotopic, that is outside the peritoneal cavity. Natural pregnancy is possible in orthotopic tissue because it is within the cavity, and the same way as the ovum is released, the tubes may pick it up. Whereas in pelvic cavities, that peritoneal fluid and specific oxygenation is likely to be a better area of follicular development. Restoration of endocrine function possible with heterotopic ovarian transplantation. So in heterotropic, probably the ovarian function is all right, but as far as retrieval is concerned, we have to retrieve, there can be a possibility of natural pregnancy. Technique of reimplantation, again, you have to master this. Technique starts with the decortication of the ovary first, and a large piece of ovarian cortex is removed. to have access to the medulla and the vascular network. Then the other tissue, cryopreserved tissue, is inserted into that. Even if this area shows some signs of fibrosis, a vascular network is still present, albeit significantly reduced. So usually we freshen up the areas. Ovarian cortex pieces fixed with the use of 7 or 8 propylene stitches, or simply placed in the medulla and fixed with interseed or fibrin glue. It sounds all very easy. Actually, technically, it is not very difficult. We have been used to taking wedge biopsies in the past. We can always, take incisions on the ovaries, remove some of the cortex. They'll be bleeding. The bleeding is, if it is not very high, it's good for actually, instead of having fibrosis there. And you just keep these pieces. Even if you don't have glue and other things, maybe you can just stitch off the cortex. So technique of reimplantation, if ovaries are absent in the particular young girl, if you have removed the ovaries, especially in the Turners or in the others, sexual transgenders and others. So a peritoneal window may be created through an incision in the anterior leaf of the broad ligament in an area where vascular network is visible. So basically, you need some vascularity to take over the implantation. The fragments are placed in the window and subsequently covered with the interseed and edges of which are fixed with the fibrin glue. The peritoneal window method may also be performed if a non-functional ovary is still in the place. So it finally looks like something like this. We all have stitched up the pieces of the cortex, and the other one is cortex implantation in the peritoneal pocket. The first one is in the ovarian medulla. The second one is in the peritoneal pocket. So embryo preservation, 95% survival rate. I have been telling this, embryo preservation is the best and the best and the best. Assessment of sperm provider is, important. Benefit, again, higher success rate. Disadvantage is loss of fertility, autonomy, because you are forced to have a IVF either with a husband's sperm or with a partner's sperm or some donor sperm. Many ladies would like to take that decision later in life, so they would like only the oocyte preservation. Storage consent is very important before you store. There are so many embryos now in the storage all over the world waiting for the wombs. This can be ethical issue, this can be legal issue, this can be so many issues. So consent is important. If embryo, especially both gamete providers, consent is very important if you're doing embryo preservation. Posthumous use, additional screening of genetic material is very important for use of surrogate. Maximum period where we can do all this is 55 years, not beyond that. It's not advisable. As far as breast cancer is concerned, I've told this earlier also, ER status is very important because the drugs that we use can give rise to high estrogen levels in the body, which will encourage the breast cancer to grow. BRCA status is important. Fertility preservation before chemotherapy and radiotherapy is the best, not after even one cycle. Letrozole 5 mg throughout the stimulation and until the period. If post-TT, tamoxifen, avoid pregnancy usually for 5 years. Washout period is always better after you give a chemotherapy. For endometrial cancer, high-dose progesterone to be used to treat the endometrial cancer. Meanwhile, you do the embryo creation, and before that, rather, not even meanwhile, before that, you create the embryos, cryopreserve it. You don't transfer it. FET after one negative result of EB following the progesterone treatment. Typically, what happens in these cases, of course, the early cases only, 6 months of very high dose of progesterone is given. Before that itself, you would have done the IVF and you would have preserved the embryos. And after that, you do an endometrial biopsy to make sure that the cancer is under control or it is not there at all. Then you transfer the embryo, she becomes pregnant, deliver her, and after delivery, you go for hysterectomy. Of course, if the patient says, I want to have one more child, I don't know how to tackle that issue. But usually, generally, after one pregnancy, we must consider to go for hysterectomy. Cancer cervix, of course, the fertility preserving surgeries are basically two. One is LETS, other one is trachelectomy. Both of them can give rise to cervical incompetence once she becomes pregnant. So once she is pregnant, cervical encerclage is a must. The latter is not a fertility preserving surgery. First two are. The other one is just a complementary surgery for a successful pregnancy. Planning the pregnancy, of course, it's a multidisciplinary approach. Preconception advice is very, very important from a fertility specialist, from the oncologist, from the oncosurgeon, and social counselor. Everybody is required, even the family, parents, all sorts of people, husband, spouse, partner is very, very important. In younger age group, of course, it is mainly parents, their consent or assent is very, very important. At least 12 months post chemotherapy for most. Usually if they have already, had their embryos waiting for transfer, it is better to wait for a complete washout of at least 12 months after the chemotherapy. Even if they are in a hurry, we should, convince them that it's better after 12 months of washout period. If radiotherapy to the uterus, dose, and age-related pregnancy complication risks are always there, because the uterus usually undergoes fibrosis, and even there will be constriction of the vagina and other things. Transfer may be difficult. Surrogacy is probably better in such situations. After tamoxifen, 3 months washout period is a must. Gender dysphoria on trans men planning surgery. This is a very important issue, gender dysphoria. Male fertility preservation, yes, I told you, number two, second best is sperm cryopreservation, which is easier compared to home preservation, because the sperm retrieval is not at all an issue. They can easily give us the semen and we can take out the sperms and preserve them. The quality, we have to assess the quality before we preserve them. May use, in fact, if you preserve the sperms, you don't have to always go for IVF. You can try 1 or 2 cycles of IUI and or IVF ICSI, depending upon the quality or the situation of the couple. SSR, if not able to provide the sample, of course, the sperm retrieval technique. I was promising that I will talk about GnRH and ovarian protection. It's an ongoing controversy. That's why I've kept it in the end. Primordial follicles that constitute the ovarian reserve are quiescent and do not express gonadotrophin or GnRH receptors. This has to be kept in mind before you load her with GnRH analogs. Of course, you can make money by injecting her, but you should keep in mind primordial follicles do not express gonadotrophin or GnRH receptors. Don't unnecessarily give it to a very young girls, or if there is only primordial follicles that we see. Gonadotoxic agents induce primordial follicle death via inducing DNA double-stranded breaks in the oocyte and a non-cell cycle dependent fashion. No mechanism for ovarian suppression by GnRH analog to prevent chemotherapy-induced DNA damage. See, you may be thinking that you are preventing the damage by suppressing the ovaries by giving GnRH analogs, but we do not understand the mechanism yet. GnRH analog induces a hormonal state similar to prepubertal stage. Like in the prepubertal stage, GnRH is not at all secreted. There's a sort of, the standstill there. There is no trigger. So even if ovarian suppression were to be protective, children of prepubertal age would be resistant to gonadotoxic effects of chemotherapy, which is shown to be not the case. So the whole concept may not be correct, that the prepubertal gonads are not affected by the chemotherapy itself is questionable. If that is questionable, then giving GnRH analog to push them to a prepubertal state, whether it is correct or not, is controversial. What are the future directions in female fertility preservation? IVM, that is in vitro maturation, is coming up in a very big way. In vitro maturation after ex vivo extraction. It is again, experimental, only when ovarian stimulation is not feasible. So what you do is you just take the primordial follicles eggs only, because you cannot stimulate these eggs and there's no time, and you mature them in vitro. I mean, this is not yet mastered. V-shaped microwell plates have allowed maintenance of 3D follicular architecture while promoting growth and differentiation of human follicles up to the antral formation after 28 days in vitro. Well, a day will come that this will become a routine procedure for all of us. Till then, it is experimental, and we have to wait for that. This is the picture how it is seen. Thank you so much. I hope I have given a broad idea about the fertility preservation for the basic doctors, basic PGs, that is those who are going to go for MS exam. This will also help the onco-fertility specialist and infertility specialist. Thank you so much. Let's meet with another talk another day.